Chapter 35 discusses environmental emergencies. So our exposure to cold, to heat, we've got bites and stings, water-related emergencies, and then some high altitude emergencies. So you guys are no stranger to cold, especially, where we live. So exposure might not be the only danger. We need to look at pre-existing or it could promote their pre-existing conditions. So how we lose heat. So through conduction is direct contact. So water chill. So you have to be touching something. Convection, air, water carry away that heat. So think of your wind chill, right? So if our temperature is 29 degrees, if we've got a wind chill, that can very well put it into the below zero range. Radiation is when heat is picked up by surrounding air or water. Evaporation, just think of when the body sweats, gets wet, we're going to lose heat that way. And respiration, so loss of body heat, just like that sounds, respirations through exhaled air. So this picture here, as you can see, convection, the body heat is lost to the surrounding air, okay, which becomes warmer or as it rises and is replaced with cooler air. Radiation, the heat's lost to the atmosphere or nearby objects without having to even touch them. Respiration, heat is lost through. You exhale warm air from the body and then you inhale the outside temperature when it's cool. Evaporation, perspiration or wet skin, sweat, the body loses heat when that liquid starts to evaporate. And conduction, and like I said, conduction is, look at this guy, he's actually sitting or touching the snow. And so it's going to cause him to, of course, cool down quickly. So we know exposure to prolonged cold is going to reduce our body heat temperature. The body's not going to be able to compensate for that eventually, and it could lead to death. So predispositions, any pre-existing conditions, hypoglycemia, shock, infection, drug or alcohol use is going to affect that. Overdoses, poisoning, any trauma. Geriatrics, you know that they're not going to be able to compensate as well as either our pediatrics are. So geriatrics, we have to be careful. How many times have you gone into your grandparents' house and it seems to be 85 degrees in there? It's because they can't maintain it as people age, they can't maintain that constant body temperature. Their vasculature is compromised. And so they're going to, usually have require warmer conditions to maintain that body temperature. Pediatrics, young kids, large skin surface area in relation to the body mass as a whole. They don't have a lot of body fat, so they are especially prone to hypothermia. And they can't shiver as much due to that small muscle mass. Systems are still immature, still developing. So assessing your patients in the early stages, a lot of shivering, we've all been there. Start eventually that numbness or reduced loss of sense, of touch, start getting stiff, rigid, start getting sleepy, breathing and pulse is affected, motor coordination starts to become compromised, joints, muscles start getting stiff, painful possibly, altered mental status sets in. We always check the core on hypothermic emergencies. The extremities are going to get cold first, as the body starts to shut the blood in shock. So check the core. You may see pale cyanotic skin if they're outside, red skin. So passive rewarming procedures, cover your patient, layer with blankets, turn the heat up in the ambulance, get the wet clothing off of your patient. For active rewarming, we're going to apply external heat sources. So your hot packs, get those into those targeted areas. So, your armpits, your groin, your head is a huge heat loss. So get that covered. Provide for shock. It says give patient warm liquids. I would deter from doing that. Transport your patient unless it's real mild. So extreme hypothermia, your patient's unconscious. We're not seeing discernible vital signs. If there's no pulse, start CPR. So the kind of the saying is you're not dead until you're warm and dead. Make sure that you're following protocol. Make sure that you're calling medical control, letting them know how long this person was down, what you're seeing, and they're going to be able to assist you with whether or not to start CPR. Make sure if they're unresponsive, not responding appropriately, protect your airway, high concentration oxygen, get them nice and cozy and warm with blankets, and turn your temp up in the ambulance and get them transported quickly. So localized cold injuries, frostbite, we've kind of all probably been once again exposed to some degree of frost nip or frostbite. So frost nip is early, superficial, get out of the cold, warm it up. We never rub any extremities to get things going, and you always handle these patients very gently. They can go into ventricular fibrillation if handled roughly, just because everything's compromised, so please be aware of that. Late deep frostbite, we're going to give them high flow oxygen. We're going to handle them gently, just like I said. So there's your frostbite. You're not going to be able to regain that tissue. That tissue is not going to grow back. It's going to be compromised, and it's going to irritate your patient when they're re-exposed to the cold. So I have frostbite in one of my fingers. Like I said, it doesn't really go away, and it tends to flare up when I'm out in the cold for an extended period of time. It starts to be painful. That tissue area right there that's dark is dead tissue. It's not, like I said, it's not going to grow back, but there are still nerve endings surrounding that area that are going to, could signal painful, still being very painful for your patient. So active rewarming, we really don't do an active like dumping people into warm water, things like that. So unless medical control tells you we're not going to use the warm water in containers, we're going to do other methods. We have, hot packs, we have blankets, we have temperature control in the ambulance. Just get them out of the cold. So I'm going to kind of skip that active rewarming. Heat exhaustion or heat stroke. So heat exhaustion. So heat cramps, heat exhaustion, that's going to be your initial step, your initial effect, not step. Moist, pale, sweaty, may have some body aches. Heat stroke is the more extreme measure of that. And you're going to see patients that have hot, dry skin. So heat exhaustion, sweating continues, the body loses salt. So our body is a big, it needs salt, potassium balance. That's a whole new class, a whole semester. The body loses salts, brings on cramps. So, when people are running these Ragnar events and those type of races, 5Ks, 10Ks, become really crampy. You see, they always have bananas there. It's, they're getting the potassium salt replacement because your body is part salt, right? Your fluids in your system are salt-based. That's what our saline solution is when we do IVs. So, get them out of the heat. They could be sick to their stomach. That's kind of common too. You might see some signs of shock. Check your oxygen level, loosen, remove clothing, lay them down. Once again, be careful giving them water. We don't want them guzzling water, but if you're at one of these race events, we have done that, and just make sure they're sipping and not gulping, because you're going to initiate them being sick and throwing up. Moist towels over cramped muscles or over the heat areas, those targeted areas again. So back, the head, the groin, the armpit area. You have irrigation solution in the ambulance. You have saline solution in the ambulance. That's plenty cool. You don't have to do ice cold you don't want to shock the system. So just using that room temperature solutions and getting them on a towel is going to cool them down. Remember, they are hot. So that's going to be enough of an adjustment just at room temperature. Heat stroke is a true emergency. It is a late stage. The body cannot regulate the temperature. And the telltale sign of heat stroke versus heat exhaustion is that ability to sweat. And you'll see your patients that have that dry skin and they're not able to lose that heat through evaporation anymore. They can be serious signs and symptoms. They could even be unconscious. You're going to see your shock systems, the shock signs, high pulse, no perspiration, pupils may be dilated. You might see them even seizing. So get them out of that hot environment. Once again, get them in your ambo, get that air conditioning going. Cool packs to the neck, groin, armpits, as I said. Remember, for infants or young kids, cooling is started using lukewarm temperature. We never shock the system. You'll get kids even with febrile seizures, which is that fever-based seizure. Lukewarm temperature, your irrigation solution is plenty. Remember, you got people that are at 104, 105 degrees. So even that room temperature, let's say it's 70 to 75, that's quite a change from where they're at. So transport immediately, make sure that the hospital knows what's going on. So you're going to see as the body temperature starts to come down, that's why we want to control the coolness on what we're applying. So muscles, they're going to shiver because you're trying to do some cooling methods. The heart is prone to dysrhythmia on extreme cold and extreme heat, so be careful there. This nervous system is sluggish, coordination stinks, they might be altered. So the skin's going to start to lose, like I said, it's going to become hot. Water related, we've got lots of water activities around these great Midwestern states, so we will see accidents regarding that. Anything from diving accidents to cardiac arrest to trauma. Alcohol is involved, a lot when we're on the rivers, on the lakes. Drownings. So drowning, there's your formal definition of drowning. Experiencing respiratory impairment from submersion, right? So just like pneumonia, when the lungs are filled with fluid, it doesn't go over well. We cannot have respiratory exchange. Same thing in drowning. So the biggest thing here is, these patients, these people they keep struggling. When they start to submerge, they take that deep, deep breath as a last resort. And then as they go under the water, enters the airway, coughing, swallowing. And so they're basically aspirating and they swallow more water. The larynx starts to spasm, starts to try to protect the airway, and then they ultimately go unconscious because of low oxygen. So rescue breathing immediately. If the patient's not breathing, you have to make sure that we're protecting, look at their mechanism of injury, what happened, how they go in the water. We might have to do some spinal immobilization precautions here, but get your rescue breathing started. You may encounter resistance, of course. You might have to ventilate a little more forcefully. You have water in the lungs. Unconscious patient, head injury patient, like I said, you're going to have to immobilize. Resuscitation should be started, though, before you do that. If you can hold C-spine, start resuscitation, and then continue your care, that would be optimal. Like it says, take care to avoid aggravating spinal injury, but we do not want to delay basic life support, of course, or you're not going to have a patient. Diving accidents, most involve the head and the neck, spine, hands, feet, ribs. So diving, they dive into shallow, they can snap their, hit their head, snap their neck back. The force of that is going to also affect your spine. So just think of that mechanism of injury. Your emergency care is the same for any patient out of the water. So just put spinal precautions in place is the biggest thing with your diving accidents. Arterial gas embolism. So there are scuba divers around here. Some of my students have informed me, or even rescue teams involved. Got a couple of different trauma events that happen during that. So arterial gas embolism is gas bubbles in the bloodstream. Diver holds breath. If they have equipment failure, an underwater emergency, anything that basically goes wrong. So an air embolism in the bloodstream, you're going to see altered mental status. They may be going in and out of consciousness. blurred vision, seizures, respiratory issues on up to, of course, cardiac arrest. Paralysis or paresthesia, and paresthesia is that tingling, that pins and needles feeling, like when your feet fall asleep, think of it that way, in the extremities, possible stroke. The thing is with these, unless we know they've been diving, it's going to be really hard for us to say, oh yes, this is an air, an air embolism, of course. So try to get the history of what's going on with this patient. Decompression sickness is when the diver surfaces too quickly from being underwater, for a prolonged period of time. It is delayed 1 to 48 hours to appear. And we're going to see some similar things here, just like we did with that embolism. Altered mental status, fatigue, pain in the muscles and joints, called the bends. So if you've ever heard the term the bends, it's real achiness following decompression sickness. Modeling of the skin, paralysis, numbness, choking, chest pain. So once again, peripheral edema and swelling, you guys already know that that's a sign of a backup somewhere. So unless we know that they were diving or on a scuba diving excursion, it's going to be really hard to diagnose this, right? It's so generalized, these signs and symptoms, but you finding out that information and then relaying that to the emergency department is really a big factor in their care. Support your ABCs. You may need to call medical control, let them know this is an oddity, right? So that's kind of like an oddity. We don't come up with patients, very often that have these things. So make sure you call medical control if it's something weird. Water rescues, if you're involved in that, number one, guys, water rescue, ice rescue, unless you're specialized training, let's leave that to the pros, okay? If you are involved though and assist with it, the first thing we're going to try to do is hold an object out for that patient to grab, maintaining distance. Next thing, throw and tow, all right? So throwing like the life ring out. Row the boat to the patient is the next alternative. And then the last resort would be go to swim to the patient, because we don't want to become a drowning victim ourselves. And like I said, with ice rescues, number one rule, guys, is protect yourself. If this is something you're not qualified to do, you need to make sure that you have professional or you have trained staff that can assist you and call the proper additional help. When they do come out, though, it is your patient. So treating for hypothermia is the biggest one, rewarming them. Always transport these folks. They do, very, very susceptible, like I said before, with hypothermia patients. They're susceptible to ventricular fibrillation if handled roughly. They're going to need to be monitored in the hospital setting for a while to make sure all the regulatory functions of our body are returning to normal. Don't work alone. Yes. Don't walk out on the ice. Yes. You guys know that. You don't go right up to the site of a fall through in the ice. I think we've lived here long enough. I don't really need to go over that. You guys are well schooled in ice and snow. And high altitude emergencies. So if you've ever gone to the mountains, visited the mountains, what a great trip, right? Except when you start feeling sick, because we're not used to that. There's less air to breathe, decreased air pressure. So even if we're normal, healthy people, so there's less oxygen to breathe, oxygen saturation starts to lower, and they can get a condition called acute mountain sickness. Less serious cases, they just feel flu-like, low oxygen level. Just like we would with a common cold, they need to overcome this by rest and rehydration at the normal attitude. In severe cases, we're going to supplemental oxygen, and we need to get them out of that higher altitude so they can be treated. So a couple of rarities, but we'll still kind of mention them. High altitude cerebral edema. Cerebral, you know what that means. Edema is swelling, is the worst form. It's a neuro side effects, loss of your balance coordination, very fatigued, altered mental status, bad headache, loss of consciousness. So high altitude cerebral edema. What in the world are we going to do about it? Well, we're going to be detectives and say, hey, this person was in the mountains and this is what happened. And then we're going to probably call medical control, but just getting them to supportive care and getting them to the ED for evaluation and monitoring. Okay. So a lot of flu-like symptoms with this high altitude cerebral edema. Bites and stings, pretty common around here. Just a side note, did you know that all spiders are venomous? They are, just depends on how potent they are. Insect stings and bites really are rarely dangerous. We still need to treat them. The biggest threat is, of course, anaphylaxis. Get that stinger out of there, use your credit card, get the venom sac off. Here's our friend, the brown recluse. He is running around the Midwest area. The brown recluse is a nasty little guy. He inflicts a bite and the tissue starts to break down and die. These can become really large infected wounds quickly. So it basically starts killing tissue from the inside out. These guys like to hang around wooded areas. If your patient's, I don't know, like getting wood ready for the winter, these guys like to hang out in that area. So insect bite or sting, look for the sting or bite mark, puncture mark. Skin's probably irritated. It's gonna hurt. If anybody, I think all of us have been stung at one point or another. Numbness from the swelling, blistering, and then, all the way through to the point of anaphylaxis, those signs and symptoms, difficulty breathing. Treat for your anaphylaxis, you have EpiPens and you have oxygen, of course, on these patients. If they got bit by something weird, call medical control and get direction on what we need to do. Snake bites, they usually aren't life-threatening around here. Rattlers can pack a punch. If we have anaphylaxis on board, though, that kind of changes, the severity of our patient. Stay calm. Make sure it's a safe entry for you. The snake's been gotten under control. Medical control, let's call those folks before we go and put tourniquets on and immobilize and do all that. The pressure bandage has been found to be the most effective technique to slow that venom spread, so we can kind of reduce the effect in the vasculature in your circulatory system. Find the area of the snake bite, pain and swelling. Your shock symptoms are probably going to be on board. Treat for shock. Call medical control. Any jewelry on that extremity or anything, get that off, because you know that with swelling, we want that off so it doesn't get stuck on there. You can keep the bitten extremity immobilized, because the more they move that extremity around, the more that they're spreading the venom through the system. So it's kind of the pressure bandage or splinting that extremity, but let's get medical control on board and get some direction as to what they would like us to do for these patients. They may even want you to have an ALS intercept, just depending on, if you could figure out what they got bit by. Marine life, as it is, kind of rare, but poisoning, improperly prepared seafood, poisonous organisms in the fish, in the seafood, or stingrays, stings and punctures. Fresh water activates the toxins on the skin, the pain is increased. So if you're going to use salt water, you know that you guys have saline solution that we use when we give IVs. Perfect. That's got some salt in it. Rinse that area. So your critical thinking question of the day is, you are in with your family at a local lake, enjoying it, having a couple of beers, and you see a boat go over. Screams are heard. You're a marginal swimmer, so you're more of a land creature. Several civilians begin swimming out to the site and apply those concepts to learn in your scene size up and what you learned here as to what you would do. Now, I had some students tell me in the past I wouldn't do anything because I'm having a couple beers and I'm off duty and I'm at the local lake, which I absolutely understand. It kind of made me laugh. But we all know that we feel a duty to respond. So just think about what you would do or how you would control, these civilians trying to help, who you would call, what you would need to help these folks out. Okay. And that pretty much covers your Chapter 55, Environmental Emergencies. I hope it was an entertaining lecture for you, and have a great week.